recording this for those that might not be able to join us live today. Let's see how this goes. All right, got some people coming on here. Good morning, Sean. Welcome in. And I'm here on the link as well. So I'm on a Peloton bike that I picked up this past week. Reason being, this is the hazards of getting old. About 2 months ago now, I was in the dog park with my brother-in-law. He with his 60-pound Doberman puppy, not really a puppy, but I don't know, she's a year old, I think. And my little Fife dog rough girl, 20-pound mini Aussie Shepherd that the two dogs are quite competitive with each other. And I flung the ball for my doggie. She brought it back and I was bending down foolishly, pivoting on one leg, right about the time that my brother-in-law decided to fling his dog's ball directly over my head. And his dog spun around and decided the quickest route to his ball was right through my lateral knee. So net result of that was a grade 2 sprain of the MCL and a horizontal, well, at least on the MRI, it showed a horizontal tear of the medial meniscus on that side. Joint space well preserved, which is good, given that I've had pretty substantial knee issues orthopedically going back to sporting days and things of that sort. But my running is on hold right now because the knee doesn't tolerate it so much. And I got to get my cardio on a little more consistently. And I also want to be able to get my HIIT training in. And this is a good way to do it without too much banging on the knee. So meat problems do happen, NCA team. Who'd have thought? Nice thing is I like how quiet this is, so we can have a back and forth like this, perhaps. And I can get a little zone 2 going on. Let me get my data going. And we could chat a little bit about, yeah, dog trauma, Jerome, you're right. Yeah, that is, I think it's a sure sign of getting old. Yeah, this wasn't a twisting injury in some exotic sporting event. 60-year-old male presents with injury in a dog park. How demoralizing. Okay. Yeah, about as demoralizing as the fiber supplement I put in with my water. Along with the creatine and the collagen and all that stuff. Folks are still joining in here. Here's Mark Heller coming on. Good morning, Mark. Nice to see you here. Mark and I have been back and forth this morning a few times. Mark, do you mind if I read a little bit of your email that you were kind enough to send? You're on mute. Mark, do you mind if I read some of that email?
That would be fine.
Okie doke.
It'd be great.
So Mark was kind enough this morning to provide a little feedback about his experience with the NCA Online Academy. For those of you who don't know Mark, gosh, our relationship really kind of started, I think, Mark, with the very first continuing education program that I ever did, which was with George Roth, tensegrity therapy. I was in like second quarter, I think, at Western States at that time. And you and I wound up showing up at the same presentation for tensegrity therapy. So yeah, we've been circling each other for a good long time. Mark, how long you been in practice, mate?
43 years.
33 years in
Oh,
practice.
43.
43 years in practice.
3.
And Mark is a columnist, regular columnist for DC Online. He's been very kind to Justin and myself over the years with his vocalizing about the effects that he's had on his on using at that point YAP and DTM primarily. So this NCA thing, however, is kind of coming up underneath all of that and providing a little more of a rationale and a premise behind why you do a technique like DTM. So Mark most recently was on the NCA Online Academy, which you can be too if you want to. It is a member program. You can go over to the NeuroCentric Approach Online website and find links to it. But Mark took the shoulder course on there first. He's completed that. And he sends me this very nice email. It says, first, I worked on 2 people close to me yesterday after watching the shoulder videos. Both had quite chronic problems. One was a frozen shoulder. Let's see, had not so bad pain, but still lacked abduction over 100 degrees. Did the manual therapy portion for the frozen shoulder that was demonstrated on that with closed pack positioning and mobilizations for external and internal rotation, and immediately had a 20-degree change in abduction range of motion. That's nice. There's still room for manual therapy in this program, guys. I do it all the time with every single patient. And the second person had severe left shoulder arthritis, and Mark says was feeling hopeless about her left shoulder. The index movement was abduction, which was limited to 70 degrees. And the primary thing that he did was cross fiber over the suprascapular nerve at the top of the shoulder, and also followed the radial nerve, downward radial nerve restriction work. And this person, feeling hopeless about her left shoulder, had immediate changes in abduction from 70 degrees to 120, and better the next day. So the better the next day is the fun part in this as well. There are those out there in the Twitterverse and whatever else that will say that these kinds of quick changes that we can see from manipulating nerves that are in trouble. Well, I'll take that last part away. The quick changes that we see in these kinds of patient interventions is a parlor trick, and it's schmaltzy, it's overly promotional, and that it's short-lived. That the only way we can get long-term benefit is with long, steady state work. And I would suggest that it all depends on the tissue that you're playing with. If you're playing with a nerve that's unhappy and you make it less unhappy and it's still responsive because it still has good metabolic health, it's not been overly compressed for too long of a period of time to the point that you've got some sort of long-term permanent damage to that nerve, then that person will have quick benefit. If you bother to actually tell them what the hell's going on and you reorganize their home care to focus on simple things that they can do for that, those benefits will be very long lasting. I see it, have seen it now for 15 years consistently. It's not always the issue. I am not suggesting that every single thing that those of us playing in physical medicine are seeing is a nerve problem. It's not. My left knee is not a nerve problem. Well, possibly. You think I might be investigating the possibility of a saphenous nerve getting tangled up in that repair process? Yeah, I am. But I had a dog problem with my left knee. It wasn't a nerve problem. So yeah, the idea is to make sure you're looking for neurology that is getting in the way of the function of that particular patient and conceptualizing why it might be happening and to
I got
refer
questions, Phil.
appropriately. Yes, sir. What you got, Mark?
Well, I'm trying to understand when I put a suction cup over the tip of the shoulder, and then have the person raise their arm, is that supraclavicular nerve or suprascapular nerve? And I'm also trying to understand the anatomy of where we're working on the suprascapular nerve. I know it's underneath the upper trapezius. I know there's a place that nerve dives down there. Okay, you want to elucidate a little more?
Sure. Yeah, because suprascapular nerve, in my experience, is a pretty common one here, especially if we evaluate in that shoulder pain patient what the status of their lower cervical spine might be like, such that there might be things there that are contributing to this. If the person has some irritation, call it a joint derangement pattern per McKenzie at C5-6, C6-7, then we're likely to have 4 nerves in a shoulder pain patient that start to show symptoms. One would be the dorsal scapular nerve exiting right through the middle scalene, turning backwards and going under the upper trapezius to provide motor to the rhomboid muscles. And there is a lot of that pain that we see in patients when they tilt their head back that radiates down to the medial border of the scapula. The other, 2 of the other nerves that we'll commonly see, and these would be in your shoulder pain patients, if you've got a neck issue going on, a joint derangement pattern, would be patients with pain on the posterior shoulder. And that is most, in my experience, most commonly the radial nerve in the triangular interval there. And I think a lot of what we have historically been treating as a subscapularis trigger point in the patient's armpit with that presentation is probably radial nerve in that interface. The other is the axillary nerve in the quadrangular interval there. Now, to answer your question, the suprascapular nerve, after it comes off up here, as you mentioned, goes deep to the upper trapezius. The way that I get to it, Mark, as I'm demonstrating right now, you take fingers, and I would typically do this from behind and hook and pull the upper trapezius a little bit out of the way. Then I'll drop down right in that supraclavicular fossa.
So I'm in front of the upper trapezius, correct?
Correct.
Okay.
And then you're going to move laterally, and you're roughly in the area at that point of where the suprascapular nerve interacts with the belly of the supraspinatus. And then the nerve will continue to a pretty common interface point where we'll have an interface issue right underneath the scapular spine, underneath that little restraining ligament right there, where it sends a chute off to the supraspinatus and another chute that goes to the infraspinatus. And you can what I think we're doing with our cups, primarily when you put a cup on the superior shoulder, you're probably modulating that interface right there. You can get in with your fingers and be a little more specific as well. The one that I find the most benefit with is right there in the supraclavicular fossa. And it's easy to do with the patient as well, because in your seated portion of your exam, as they typically, with that shoulder pain patient, reporting that elevation, either in abduction or flexion, is the painful range of motion. As they do that, you can very quickly, just as we demonstrated in that video, Mark, on the course, you can sit behind them or stand behind them and lift on their neck and provide traction and see if their range of motion changes. And that would implicate something that is narrowing the neuroforamen in the neck as being contributory to the presentation. And then you can get in on the suprascapular nerve right there. And I generally, my objective as I get on it with that hook position from behind is I think I'm trying to get on the front side, the anterior aspect of that nerve's travel. And I'll palpate through there and see if I can hallucinate the nerve and then pull on that which would create a bit of a different interface all down that neural path, and have the patient repeat their index, and we see if they've got any improvement there. And if they do, then I'm going to spend a little bit more time on that. And I'll commonly treat that in supine as well, seated at the head of the table and working in with transverse nerve mobilization while the patient works their arm around, which brings up a bit of a important point on the way that we apply the neurocentric approach stuff. We're looking to not only to change that interface with our manual contact, we also want to include some kind of improvement by using patient movement, ideally. So that gives us a little bit of that flossing stuff that we'll commonly have. To go back, I think we've talked about this on some of these other ones, but I see it so commonly, and I see it as a lovely way of highlighting sort of the integration of multiple neurally focused components that we're trying to do with NCA, is that patient with neck pain, possibly shoulder pain, but the pain radiating down the middle towards the medial border of the scapula. And that patient, I've found, often will report that their symptoms tend to get worse when they're stressed out. And in addition to the effects of cortisol and the other catecholamine hormones on neurology and reducing the action potential in those kinds of sensory nerves, the effects there can be heightened if you increase the mechanical pressure on the nerve right there at the middle scalene. How does a stressed out person breathe? High, shallow, rapid, apical breathing pattern. So when that person gets stressed out, you got potentially one more thing right here. And most of us these days, we are often, a lot of the sources of our stress tend to be anchored around devices like what I'm playing with right here. We have a job or some sort of thing that we're doing, or trying to meet a deadline, or you're trying to go through some kind of stupid effing battle on social media. And that kind of stuff can get you breathing wrong. You get all up here. And then we've got the potential for one more little interface problem with that, that piece of neurology in that area. And commonly I'll see that patient as well has a medial winging of the scapula on that side if the motor function of that rhomboid is somewhat compromised because of chronic compression of that suprascapular nerve. Why I'm bringing this up is it gives us a nice inroad now in a patient that presents with neck pain. It gives us a nice inroad to talk a bit about a more holistic approach to addressing the things that they're doing. You know, patients come to us in pain commonly doing the kind of work that we do. And their stated goal for the visit is to reduce their pain, but really what they want is improved function. They want to get their life back. You got to love hearing that one all the time. So if you push them a little bit more, you can have a bigger impact on their life with this kind of approach, I think. Certainly been what I've seen over the years in practice. And, you know, it doesn't mean that you have to be the one to weigh in on all of that stress stuff. Just know how to refer appropriately. Make sure you've got some psychologists, some therapists in your referral Rolodex, for those of you that know what the hell that is, and get in touch with those folks. At least, at the very least, get the patient aware of that relationship. I see that one as well. Many years ago, Lorimer Mosley did a video, DVD set. He described some of the research on the way that nociceptive neurons, particularly C fiber afferents, can get primed to ping in the presence of catecholamine hormones. And the story is one that we commonly see with patients that have been in a rear impact motor vehicle accident. So you guys are aware of the shear forces in the lower cervical spine and the closing and possible facet imbrication at the upper cervical spine and that mechanism of injury. And commonly, people that have been through that kind of thing, they feel a sense of victimization, right? They're like, you know, I was doing everything right. I was stopped at the light. I was paying attention to the road. I wasn't playing with my phone or whatever. And somebody, you know, slammed into me from behind. And now I've got all these doctor visits I got to go do. I've got all this stress associated with the dealing with the insurance company and all of that. And in those cases, one of the key things I ask in history was what their life was like from a stress perspective when all of that occurred. Because Mosley, in the way that he brought that up, those sensory nerves around the injured spinal tissues are nociceptive neurons, and you guys remember that nociceptive neurons respond to intense pressure, intense heat, and chemical changes in the tissues. They cause that nerve to report upstream to the spinal cord and then onto the brain that something's going on in those particular tissues. And when that occurs, in the presence of catecholamine hormones, because the patient was going through quite a bit of stress at that particular time when they suffered the injury, then those nociceptive neurons will become primed to chemically respond to the presence of catecholamine hormones. Now, I do not know the half-life there and how long that's going to stay, but I set the patient up for the possibility that at least a portion of the symptoms they are feeling in their neck might be just because they're stressed out because the release of the catecholamine hormones will cause the nociceptor to fire, and the brain has to figure out what the hell's going on. And the common presentation I might see down the road months after is the patient's doing great. Their range of motion is great. Their function is restored. Their NDI score is beautiful. And then they come in to an appointment and they're like, and I ask them how they're doing. I'm like, when is this thing going to be done? Why am I still injured? Because their tissues from all of the other metrics that you've been using, range of motion, palpation, function, have healed. And yet, periodically, bam, they can get intense pain in their neck. And I think part of it is that those catecholamine hormones get released. The patient has a firing of that nociceptive neuron. The brain from on high looks down the tunnel and says, okay, who's talking down there and why? And based on collected experience in your hippocampus and amygdala, that brain says, oh, looks like it must be that injury is still causing some issues there. So if you drop that info on the patient as a possibility in visit number 1 with that MVA, now you have an off-ramp in that patient, if that comes up down the way, to get off of their hysterics, potentially, and hypervigilance, treatment seeking, and all the other fun things. So just some thoughts musing there. Justin, you're on this morning. See you on there. You want to come in and talk a little bit?
Good morning, everyone. How are you?
Peachy Keen.
So I came in a little late because I had a business call this morning. Was there a case that I should chime in on, or just in general additions?
We were, let me mute you there for a sec. We were talking, Mark and I, about some shoulder issues and talking specifically about location, path, and function of the suprascapular nerve in shoulder presentations. And so, yeah, if you've got some recent cases in regards to that you want to chat about, go with it.
Yeah, absolutely. So one of the things I've been working on recently that I have not had a chance to share with you is the capsular mobilizations for the neurology around the glenohumeral capsule. As far as I've had some very interesting, I would call it freezing shoulders in the freezing phase. Been able to clear it up quite quickly by working that suprascapular nerve, as well as primarily the nerve subscapularis, like making sure that those articular branches enter the glenohumeral capsule, making sure that those guys are moving as just as good as possible. And I'm sorry if I'm seeming a little groggy. I'm still waiting for that old coffee to kick in. But oh gosh, I'm looking forward to sharing this information, because it's the same concept as the hip, where you are aligning tension to the capsular orientation of the tissue, in contrast to the nerve insertion point, to create a shear force between the two.
Yeah,
Not
that
see a
is,
video.
that's good stuff. I look forward to seeing what you've got there as well. That hip info, Justin, that you put together for the lower quarter course. That hip info that you put together with the obturator nerve and its spray patterns of innervation of the hip capsule, and then subsequently theorizing according to the various ways that the hip capsule fiber orientation can be, adding manual therapy techniques to theoretically try to get in and work that interface between the obturator nerve and the hip capsule itself. And I find that that is a really delightful way to play that. It's like putting a cherry on top of the rest of the work that I'm doing on that particular hip. I've got one of those cases to talk a little bit about too, that I'll flesh out over coming weeks as we get more detail. But first, I'd like to say hello to my old classmate, Alan Jinks. Alan, good morning. Are you
Good morning, everybody?
Good morning. Are you in Kelowna today?
No, I'm down in Vancouver.
Ah, all right. Say hello to my son. He's a brand new Canadian citizen.
Oh, okay.
I sent my best, the best work I've ever done. I sent to Canada, and you guys didn't give him back.
That's good. We need him up here.
Yeah, no doubt. He just got full-on citizenship last week.
Okay.
And now I got to learn how to sing "Oh Canada." So,
Well, you don't, he does.
well, you know, I want to join in. Maybe
Oh,
I
okay.
can, maybe I can hit a harmony somewhere in there.
Yeah, all right. Yeah, that's good. Yeah, we could use that too.
All right, so back to the hip stuff. And for you guys that are wondering what I'm talking about, the courses and the hip firing pattern, all that stuff, that is material that we have available in the online, the in-person course for the lower quarter. We've got an upper quarter and a lower quarter, each 12-hour courses. We're starting to book in-person coursework now. But the work that we have online on the online academy is a good place to get your feet wet, or if you've been to those courses already, it's a good way to review some of that. And members, lifetime members to the site, will get $100 off of those in-person courses when we launch those. Now, a case that Justin, I'd be interested in your input here as well. But and this individual has given me license to talk about his case in this kind of an environment. But many of you know that I've got an office at Kabuki Strength Lab, and that one of the founders of Kabuki Strength Lab is Rudy Kadlub. And Rudy is, for the last 10 years or so, he's been the age and his age and weight class has been the world record holder in all three lifts and cumulative totals in the sport of powerlifting. He's an incredible individual, one of the most delightful, gentle, wonderful, and giving human beings you're going to run into. And Rudy has really not had all that much coaching from the coaches at Kabuki, because he's very self-sufficient. And, you know, it's one of those things where if you're functioning at that high a level, why mess with it? You know? And he's been doing so well for so long that he's mostly just him and his training partner showing up in the gym. And every now and then we'll have a little bit of a tweak, as happens in this population, and their training blocks as they're preparing for competition. And Rudy is getting ready for Worlds, another Worlds event in November, I believe it is. And Rudy's weird because he's at an age where we are supposed to be getting weaker. He's 75. Research would suggest that I think it's after your 40s, every decade, we lose about 10% of strength. Rudy has improved in strength on all 3 of his lifts for 5 years running. I will show at some point, because he's developed a habit on his birthday of attempting a PR on a deadlift. And he did that in the gym this year. And not only did he increase his PR by 1 or 2 pounds, just on a lark, he pulled it for 2 reps. He's incredible. But the last 2 times that I've seen him over the last year and a half or so, and his training blocks for little tweaks that he had, I've noticed kind of disturbingly that this area in here was moving off, shall we say, off-piste. And from a DNS perspective, he was starting to exhibit some classical problems in here, showing a really pronounced rectus diastasis. And on a recent presentation, we had, with some groin pain that he had, I was working the stuff that Justin was talking about a moment ago regarding the hip joint and the obturator nerve. And I was able to help him dramatically, very quickly, by working a putative obturator interface issue between the adductor longus and adductor, 2 of the adductors. And in that was lovely to see, but he still had some issues, and his exam also showed some potential meat-based involvement at the hip joint itself, which I would completely expect in a 75-year-old athlete like that. So just the other day, we were working on this again because I'd make it feel better with the obturator nerve stuff, show him stuff that he could do, and then he would come back. And we doubled down on the rectus diastasis and the issues here in his middle. And he would try a wide stance, like a sumo style deadlift with no weight, and squat down, and that was his index movement. And he could consistently make it worse by moving into something that looked like a Cossack squat, moving out to the side. So he did that, and without doing anything else, I just got him to start working on a position change. What you see in a lot of powerlifters like this is as soon as you start playing with this area and you mention anything about bracing, they go full tilt boogie. So I'm like, okay, now show me a squat pattern. He's like, and squats and comes back up. I'm like, no, man, just squat to the chair, squat to the toilet. Show me something in its very low threshold and give me good position there. And we worked on the position, worked on the 4 quadrants of breathing and bracing here that they talk about, the principles of loaded movement work at Kabuki. And he dropped down in that position for the index movement, and that sumo style wide leg squat. And he's concentrating very hard on that neural engram that he's got to make it different than what he's used to. And he drops down into that, looking down at the floor, moves to the side in his little Cossack movement and looks up at me. He says, "You fucker." He's like, "It really is that simple, isn't it?" I'm like, just because you're a world record holder doesn't mean you're immune to these developmental principles that we've been using in this facility for the last 15 years. I said, it's time to put a new kitchen in to your wonderful house. We need to pull some things down to the studs. And even though right now he is still rocking his progressions on his training program, and we'll go set more world records. I mean, there's a point when you reach 75, you just outlive a lot of your competition on the platform. But he's going to go set world records. Now, in addition to making him our resident science experiment for longevity and strength training, and setting records, we want to keep his hips healthy. So we're in the process of working on that. I'll let you guys know how that progresses over the coming weeks. Anybody have any questions here?
I do, just insights on that. I'd like to get your thought on this. What I've noticed over the last 10 years with hips, or I mean, it's just more of an idea or an observation that potentially there's in relation to this diastasis in the abdominal wall, that maybe there's like an underlying like inguinal hernia type thing that's progressing. And just the way that you were describing that, like I'd love to get your insights on this idea that just by tweaking the basics there, like I wonder how much that's just reducing potential abdominal pressure there that might be reducing what otherwise would eventually become some sort of like full-blown hernia.
I agree with that and see it pretty commonly, Alan. And I'm not sure. I think we're probably working a chicken and egg scenario with that. The thing that when I try to make a narrative in my own mind that makes sense with that, the intermuscular septum between the rectus and the external oblique right here, common spot where we'll have these kinds of sports hernias, that will tend to be potentially drawn under a lot of tension if that person has that open scissors presentation and they're kind of spilling out of the front right there. Then the anterior cutaneous nerves right there that come out of that septa will get presumably some pretty significant mechanical forces placed on them. So if we improve that to get hoop stress improvements like Stu talks about, by getting better firing patterns in the transversus and in the obliques, then we should be able to reduce or at least change the putative mechanics at that interface point with that neurology. I have seen that work a lot. And I had a runner recently that was D1 runner that both Justin and I have seen over the years that was having this, and put my finger right on the pain and make the pain happen. And he went in to see his primary care, and his primary care is like, "You've got a full-on inguinal hernia. That's what's going on here." And he sent him out for ultrasound, and then ultrasound was read as negative, and his primary was really doubling down on this and sent him out for MRI. He did not have an inguinal hernia. And we just needed to do some more of the long game work on improving his stabilization pattern there by shifting him from a high threshold to a low threshold stabilization strategy and getting him functioning a little bit better. And we have, and he's running painlessly now. It just takes a little longer when you're doing doing it through that function lens exclusively. Justin, you got any input there?
Yeah. As a person who has diastasis recti and has for many years and gone through the process of quote unquote fixing it and then neglecting it and then needing to fix it again. So some of the things that I've been playing with recently is actually starting to focus in on the still doing all the functional interventions, still doing everything that we talked about, but that we would typically talk about, you and I, like, like scissor positions. But one of the things that I've been doing recently on my patients and that has helped me myself is actually working on the large, rigid structural ligaments in the front and the back of the pelvis, such as the iliolumbar ligaments and the suprapubic ligaments in the front. So both from a innervation standpoint and from a mobility, because those ligaments are quite rigid. So this is venturing a little bit outside of what we're typically teaching at NCA, but it's worth noting that when I've been treating that stuff from an osteopathic perspective, and it has helped get patients out of that anterior pelvic tilt. This is just a huge side note. I'm also looking at it. I'm looking at it from also a transverse nerve glide of the insertion of the innervating neurology of the area as they innervate those ligaments, but as well as increasing the pliability of those ligaments just a tiny bit, most likely from a neurologic perspective, to get them out of that huge anterior pelvic tilt. So I'm just going to plant that seeds for people to think about. I can't demonstrate how I would do such right now, but it is something that I've been playing with quite a bit, and it does seem to speed along the process. But obviously the functional interventions are primary.
Justin, your timing here is uncanny, and I know I'm hoping Mark was around his computer right then when you were talking about that. Mark and I have a candid enough relationship that we will each call each other out on our bullshit. And so Mark was also another email this morning said something I think you're missing are low force osteopathic techniques in this. And my comeback was, I don't know that we're missing that. You can use whatever manual therapy technique works for you. I just want you to make sure that you are incorporating the best current evidence on mechanical sensitivity of neurology, the best evidence on pain neuroscience, the best evidence on systemic issues and metabolic issues that can push sensitivity of neurology, and incorporating that in an elegant way. Whatever manual therapy, manipulation, or exercise interventions you want to do, that's great. We have a strong bias towards DNS procedures. I admittedly do not have the same skill set anywhere near approaching what Justin and his geekiness has acquired over the past 10 years of working with osteopaths to put together these kinds of low force mobilization things and such. But we do go through those in the in-person courses to at least familiarize yourself with them, and at least to give you direction to where you can deepen that investigation if you want to. I think I do have a placeholder on the online academy for a couple of courses like this, one on transverse nerve mobilizations, which was Justin's baby, and the these kinds of an introduction to these kinds of osteopathic movements. So hopefully Justin will be able to have some opportunity to put something like that together, and that'll be available on the site as another course in the not too distant future. The next course that will be available will probably be this evening. Although I will say, I'm looking outside a gorgeous northwest fall day, and I'm presented with the opportunity cost of sitting at a computer and finishing the edit and upload of that course versus going out and seeing if I can gather some chanterelle mushrooms with my doggy. So you might have to wait an extra day, but the sports hernia, athletic pubalgia course will be dropping in the next 1 to 2 days. And then the one after that will be what on tendinopathy, where I'll be just fleshing out what I think the NCA brings to the table that adds to the current theories about tendinopathy and expands on Jill Cook's work, Rio Boney's work, Karin Silbernagel's work, Paul Ackerman's work, and Brian, if that Brian that I'm seeing on here is a name, is Brian Dingser, that will address some of the things that we've gone back and forth in the community at the NCA Online Academy, and also in direct emails about that kind of stuff. I did appeal to Paul Ackerman to come on here and talk about this, but his speaking fees were richer than what we have coffers to be able to manage. So at least for right now. So I'll continue to explore that relationship. We'll see what we can get on here for visitors at some point when you're tired of talking to me and Justin. Mark and others have mentioned that we want to try to keep these meetings to an hour or less. I think that's a good strategy because, you got families, places to go, things to do, and you want to try to maybe think about this as a weekly meeting for right now with friends. So we're going to try to do that. I've got some highfalutin ideas to possibly even go back and explore some of the things that we saw historically with the Rose City Rehab Performance and Microbiology group back in the day, where we would meet in a pub every 2 weeks and talk shop. And I'm thinking of relaunching something like that. And periodically we'll have a similar kind of meeting like this, but we'll do it at a different time and with different mood alterers. And I could envision that being a hell of a lot of fun too, if we have live streams with other similar groups in other towns. I know Alan down in Van, Tony McDougall, put together the Rain City Club, I think it's called. And those guys were going strong for a period of time, but I'd like to see something like that where one group on a live stream is showing up from a pub somewhere and another group is in another location, and we switch back and forth and just basically develop a community to have fun. And I'm looking, quite honestly, to try to get the hell off of social media. But I just feel like it's toxic in so many ways. So I'm looking for a way to keep my geek community somewhat close and playful and inquisitive. And let's see what we can do to try to change the face of our professions and to help people better. On my
This is probably a topic for conversation at some point with Mark. But when I am considering what the hell it is we're doing with all of this and thinking about the trajectory of the chiropractic profession over the years too, I find it fascinating sometimes that it's almost like this NCA perspective almost seems to be a bit of an updating, perhaps, of some of the classical ideas about what the hell it is chiros are doing when they're moving joints. That would be ironic as hell for me. But I do think it's fascinating to consider. Thoughts, anyone, before we sew this up? We got about 4 minutes to go. Donna J. Crow, hello. Good to see you. Darka, nice to see you here as well. I hope all of you guys are well and enjoying your weekend. Thanks for putting up with me while I'm trying to get a little workout in here. And if I don't have any questions or considerations here, then I will hopefully see some of you guys next week. Coolio? Take care, gang.
Philip, I was wondering why you were breathing hard. I missed that you were exercising. I was literally like, I was going to ask if you were okay because you sounded short of breath.
Yeah, it sounds a little bit like those old videos we do with Chris Duffin. We're just walking across the gym floor. He'd be getting cardio. Yeah,
right.
I got to use Peloton last week, and I've retrofitted it. Took the computer off and put a stand on the front that I mounted my laptop to.
So
yeah, I've got a grade 2 MCL on the left knee and a medial meniscus tear from an encounter with a dog in the dog park. And I'm trying to figure out ways to keep my zone 2 and my HIIT training going so I can outlive all of you motherfuckers. All right, I'm gonna, since this is recording, I'm gonna go ahead and turn that recorder off. Hang on 1 second. Why won't it let me do that? Are you doing okay, Bubba?
Me, I'm doing well. Are we still recording?
Yeah, we are, unfortunately. I'm trying to.
That's
There it is. Stop recording. There we go.
That's okay.